and good morning, everyone. It's lovely to have you all here for another episode of Oral Pathology Tuesdays. Well, today we are going to be talking about essentials of lymph node pathology in oral squamous cell carcinoma. It was a very interesting week we had last time where we had some amount of technical difficulties, and for that, it's been an attempt to actually people proof or human proof technology. So today I have a panel of experts with me on Zoom. And if there is anything, they can always chip in, and they are also going to be there. So even if I get disconnected, the show can go on. I have Dr. Priya NK, who is from COTS, Davangere. She has many years of experience because COTS does a lot of oral squamous cell carcinoma cases. I have Dr. Raghu Radhakrishna, who is also, of course, known to everybody, and he is going to be the co-host. So if anything, he will take care of whatever is going on. And also Dr. Barpande, who has joined us, and possibly Dr. Hazare, and also maybe Dr. Asitwa will join us. Welcome, everybody. It is great to have all these colleagues and seniors with us. And with that, so today our speaker is Dr. Priya NS. She is the professor in Department of Oral Pathology, VS Central College and Hospital, Bangalore. She has worked as the co-editor for the Association Journal. She is pursuing her PhD right now under the RGUHS, and she has also been a very important backbone to all the programs we have been watching on Oral Pathology India. She is essentially been my volunteer team member. So in fact, even today, she has also got the controls. So if anything, she can help in with the running of the show. So with that small introduction, thank you everybody, and we shall now just go back to her. So yes, over to you, Priya.
Thank you, ma'am.
Yes, you can start your share.
Yes, ma'am. Good morning, everyone. I am happy to be here in this forum to share a bit of my experience with you all. And the reason I'm here today is Mandana ma'am. Thank you, ma'am, for allowing me to be a part of this academic collaboration. I would like to start my presentation with a quote by Christopher Reeve. Once you choose hope, anything can happen. I'm highly grateful to all the cancer patients who have suffered and endured ravages of oral cancer. And this dedication is for all those brave souls. I will take you through a short journey of a lymph node, beginning with its uniqueness to normal histology and some important matters pertaining to it. I am sure I can say there will be a visual treat on seeing the grossing pictures of lymph node involvement of our own cases. Then comes today's spotlight distinction between reactive and morphological and metastatic lymph nodes in oral squamous cell carcinoma at morphological level. Then briefly on guidelines in reporting lymph node metastasis in oral squamous cell carcinoma. The last one is for you to ponder what I might say. Have you wondered any time about an organ which is strategically located and scattered throughout the body in such large numbers? Yes, I'm talking about a lymph node, which is remarkably organized, dynamic, and an immunological organ. They are unique in the sense that they share the concept of compartmentalization or zonation. There are building blocks like cortex, medulla, paracortex, which lead to the architecture of the lymph node. The diversity lies not only in the architecture, but also with respect to the composition. So there is a cellular diversity within the lymph node, which creates a unique microenvironment. There is a adipose tissue around the lymph node. Why is that? Is it site specific to a lymph node, or does it enhance the immunity of the lymph node? Let's understand that in a while. Then coming to the functional adaptation of the lymph node. Lymph node responds to an antigen and sets in inflammation. Lymph node responds to a neoplastic cell and sets in metastatic environment. So there is always some reconstruction and remodeling happening within the lymph node. And lastly, as we all know, lymph node metastasis is an important prognostic determinant in oral squamous cell carcinoma. So all these points will make the lymph node a unique structure. Before going to the histology of lymph node, let us understand an overview of a lymph node. Lymph node is made up of three major compartments: cortex, medulla, and subcortex. And all these structures are enveloped by an outer covering called capsule. Through afferent vessels enter the capsule, and there are extensions of the capsule into the lymph node, and that is called septa trabeculae. And there is an indentation at one end that is called hilum, through which efferent lymphatics and the blood vessels go out. And other additional structures are lymphoid sinuses, which are of three types. One is subcapsular sinus, which is just below the cortex, and medullary sinuses in the medulla. And the sinus, which is around the trabeculae, is trabecular or cortical sinus. So the sites of B cell homing is usually cortex and medulla, and paracortex is the zone where there is T cell homing. Coming to the histology of capsule. So capsule is the outermost covering of a lymph node, which has fibroblast, collagen fibers, adipocytes, blood vessels. Accordingly, it can be a fibrous tissue, or it can be a fibroadipose tissue, or it can be a fibrovascular tissue. And you can see the extensions of the connective tissue into the lymph node, and this is called trabeculae or septa. So in this photomicrograph, we can see the afferent lymphatic vessels and the subcapsular sinus. We can see the draining of lymph from the afferent lymphatic vessels into the subcapsular sinus, and subcapsular sinus is connected to the medullary sinus. Coming back to the question, why there is fat around lymph node. So these are some of the gross pictures where a lymph node the fat is around the lymph node, and here again some lymph nodes with fat. This is the histological section showing adipose tissue near the capsule. So in this particular article, they mention perinodal fat as a specialized tissue. Is it because it is site specific, or it enhances the immunity of a lymph node? Let us understand through this diagram. So this is the cortex of the lymph node, and this is the capsular area, which has the adipocytes and which has afferent lymphatics. And there are three important factors which are in the red box. One is fatty acids, which are produced by the adipocytes, the dendritic cells, and the adipokines. So perinodal adipose tissue has the site-specific property of having more huge amount of unsaturated fatty acids, which help in immunity. And the adipocytes release cytokines in the form of adipokines. So they help in the migration of the dendritic cell into the lymphatic vessel. And compared to adipose tissue elsewhere in the body, perinodal adipose tissue has high number of dendritic cells. So that's why there is fat around that is the significance of fat around the lymph node, because it enhances the immunity. The next structure is a subcapsular sinus. It is one of the lymphoid sinuses which is present below the capsule. And sometimes this area is important for pathologists, because this is the area, first site where metastasis can occur. From the lymphatic vessel, metastatic cell can travel and can be seen in the subcapsular area. So when we are suspecting a lymph node metastasis, we have to make sure to look deeply into this particular area. So on the floor of the subcapsular sinuses, there is a presence of macrophages, which are called subcapsular sinus macrophages. So the role of them is they act as frontline warriors. As soon as the antigen enters, they take up the antigen and they present it to the dendritic cell and thereby to the B cells. Cortex is the major component of the lymph node. It has lymphoid follicles. One is primary follicle, another is secondary follicle. Primary follicles are round in shape. The size is usually less than 1 millimeter, and the long axis of the lymphoid follicle is usually perpendicular to the capsule. And secondary follicles are formed whenever there is antigen entering into the lymph node. The size can vary, and there is a development of mantle zone and the germinal centers, and even the orientation alters because of the development of these two structures. So secondary follicles will have a mantle zone. It is also called corona, or it is thick near the cortex area, and it is thin on the opposite side. The germinal centers are the dynamic structures which have tingible body macrophages. So these are the tingible body macrophages. So you can clearly make out a tingible body macrophage. So what is a tingible body macrophage? It is nothing but an histiocyte or a modified macrophage. The cell shape is irregular. You can see the irregular shape, and it has got abundant clear cytoplasm, and cytoplasm has got some hematoxyphilic bodies. So they represent apoptotic bodies in various states of degradation, and the nucleus can be present in the center or eccentrically placed. Nucleus usually has disposed chromatin, and that is tingible body macrophage. Tingible means stainable. Since the phagocytosed macrophage shows stainable apoptotic bodies, it is called tingible body macrophage. The second important structure of lymph node is medulla. Medulla has medullary sinuses and medullary cards. Those sinuses are sometimes empty, sometimes filled with macrophages. The medullary cards are made up of, they're nothing but the clusters of plasma cells, macrophages. And so here you can clearly make out the sinus area and the cards, medullary cards. This is again to show you the difference between the card area and the sinus area. Cards are nothing but clusters of cells. Paracortex is the structure which lies between the cortex and medulla, and it is also called interfollicular cortex or inner cortex, and it is characteristically Holmes T zone. It is a T cell zone, and it has high endothelial venule, which is also called post-capillary venules. These are nothing but the vessels with endothelial cells having a high columnar shape, and they help in recirculation of the lymphocytes, redistribution and recirculation of the lymphocytes. Sometimes the lumen is not visible at all because it is obliterated with the endothelial cells. So the diameter can vary. You can see 2-3 high endothelial venules. So this is a schematic representation to tell you the difference between the normal venule and the high endothelial venule. So here you can see within the normal venule, the flat endothelial cells. In HEV, the endothelial cells are highly columnar, and there is thickened basement membrane, and there will be a coat of pericytes. Coming to lymphatic sinuses, they can be of three types. One is subcapsular sinus, the medullary sinuses, and the trabecular sinuses. So once the lymph enters the afferent, lymph from the afferent lymphatic vessels enter into the subcapsular sinus, and then it is carried into the medullary trabecular sinuses and then to the medullary sinuses. From there, it drains into the efferent vessels and goes out of the lymph node. Hilum is the indented structure of a lymph node where there is exit of blood vessels and the presence of efferent lymph vessels. So this area will show some changes with respect to the reactive lymph node and to metastatic lymph node. So in the reactive lymph node, vascularity can be increased in the hilum region. So you can see the dilated vessels, increased vascularity, and in the metastatic lymph nodes, there can be loss of ILR region, and there will be a pattern called peripheral perfusion uh, in metastatic lymph nodes. You can see the blood vessels here. The supporting stroma is mainly reticular fibers, which act as a framework, which is nothing but type 3 collagen with a 20 nanometer diameter, which can be enhanced through silver impregnation technique of Gomori stain. And the other stromal cells are fibroblastic reticular cells, follicular dendritic cells, LECs, BEC, alpha 7 integrin pericytes, and double negative cells, which I'll not go into the depth of it. So double negative cells are cells which has the both CD4 and CD8 receptor. So double positive cells are also present. And do you see the adipose deposits within the lymph node? It sometimes there can be adipose tissue within the parenchyma of the lymph node. It can be considered as an age change or a response to inflammation. Coming to the cellular domains, we have partly covered. So cortex is a B cell zone, and it also has follicular dendritic cells, tingible body macrophages, centroblast and centrocytes in germinal center. I'll explain about this. Then medulla, mainly the medullary cords are made up of B cells, plasma cells, and macrophages. Paracortex is a T cell zone, and it also has interdigitating dendritic cells and fibroblastic reticular cells. Cervical lymphadenopathy is refers to enlargement of the lymph node with respect to size, shape, number, and consistency. Let's look at the some of the points pertaining to size. Though the lymph node size can be increased in reactive lesions and in the neoplastic lesions. So these are some of the lymph nodes resected from the neck dissection specimens, and you can see the variation in the size. Normal shape of the lymph node is kidney shape, but it can have some variations like ovoid, round, bean shaped, and you can see the fat around the lymph nodes, little elongated structures. And here also you can see the characteristic kidney shape. And metastatic lymph nodes tend to have a round shape. So this is one example. So the number of lymph nodes, it varies. In a normal young adult contains around 400 to 450 lymph nodes, with head and neck region bearing around 60 to 70 lymph nodes. Older patients may have less number of lymph nodes compared to the younger ones, and it can be absent in the newborn. And lymph node size and number is reduced with respect to previous radiation or chemotherapy. And some systemic diseases can also increase or decrease in the number of lymph nodes. So this is the level 1 lymph nodes, which are more than 25, which were resected from a neck dissection specimen. Consistency give a clue to the etiology. Normal lymph nodes are usually not palpable. In acute inflammation, lymph nodes are soft and tender. In chronic inflammation, it becomes firm, maybe because of the fibrosis. And in lymphoma, it appears firm and rubbery. And in malignancy, because of the invasion of the tumor cells, it consistency is hard. And matted lymph nodes are seen both in reactive lesions and neoplastic lesions, tuberculosis, sarcoidosis, lymphoma, and metastatic carcinomas. So coming to the grossing of the lymph nodes, grossing is an important structure for a pathologist. Uh, we can retrieve good amount of information and obtain clues if we handle the surgical specimen well. So there are four basic surgical procedures for head and neck cancers. R&D, that is radical neck dissection, which involves removal of level 1 to 4 lymph nodes along with non-lymphatic structures like sternocleidomastoid, internal jugular vein, and spinal accessory nerve. Second procedure is modified R&D, which involves removal of these nodes, sparing one of the non-lymphatic structures. Extended neck dissection involves removal of additional lymph nodes like facial nodes, buccal nodes, parotid nodes, etc. Selective neck dissection involves suprahumoid neck dissection, lateral, posterolateral, and anterior compartment. Oral cancers are we get specimens of SOND as it involves level 1 to 3. So these are some of the examples of the neck dissection specimens. So R&D can sometimes yield an average of 20 nodes ranging from 10 to 30, or it can go up to 50 to 100 nodes can be identified. So this is hemimandibulectomy specimen with SOND. We can easily make out the submandibular gland and the lymph nodes and the fat around it. And there is excision of the skin, and again hemimandibulectomy specimen. Here we can see the sternocleidomastoid, the upper head and the lower head. So there is a clue for the orientation of the radical neck dissection specimen, and it is compared to the capital letter Z. The upper horizontal line denotes the level 1 group of lymph nodes. The bottom horizontal line can represent level 5 group of lymph nodes, and the slanting oblique line can have equal divisions of level 2, 3, and 4. You can just go through this article by Slutweg, where the handling of the surgical specimens is mentioned. So after knowing the type of specimen, we should know the levels, different levels of involvement of the lymph nodes. The classification of lymph nodes according to levels is given by Robbins, and there are 6 levels. Level 1 is submental, that is submental lymph nodes, which the squamous cell carcinoma of the tip of the tongue, anterior nasal tip, and the lower lip drain into submental group of lymph nodes. 1B is a submandibular group of lymph nodes, where the squamous cell carcinoma of the oral cavity, then mid-facial region, the nasal cavity, and that drains into submandibular gland lymph nodes. Then level 2, A and B, receives lymphatic drainage from squamous cell carcinoma of the oral cavity, nasopharynx, oropharynx, uh, larynx, and the parotid lymph nodes. Level 3 group of lymph nodes are involved when there is a squamous cell carcinoma of the oral cavity, nasopharynx, oropharynx, hypopharynx, and larynx. So we usually deal with level 1 to 3 group of lymph nodes, as the drainage of tumors of the oral cavity are into these 3 group of lymph nodes. Level 4 group of lymph nodes are involved when there is squamous cell carcinoma of hypopharynx and the thyroid, mainly cervical esophagus and the larynx. Level 5 group of lymph nodes are a posterior triangular group, and the drainage is from the posterior scalp and the neck region. 6 is the central compartment, which are pre-laryngeal, pre-tracheal, and paratracheal. And group 7 is not the part of the head and neck group of lymph nodes. For the completion sake, it is included. They are the nodes of the upper mediastinum. So once we understand the type of specimen and the levels of lymph nodes involved, Next comes the sampling of the lymphoid nodes. It is important to identify the lymph nodes from the gross in the specimens. Lymph nodes appear to have smooth borders and white in color, and the adipose tissue is yellow in color. So we have to take out each node. Those discrete nodes should be dissected along with the perinodal adipose tissue. The fat should be retained, and we should avoid squeezing of the nodes as it may alter the histology of the lymph node. And when we gross, the section thickness should be 3 to 4 mm. So firstly, we have to measure the lymph node in all three dimensions, and the smaller lymph nodes can be taken in toto. There is no need to cut it. It can be taken in toto. Entire tissue is taken for processing. If the lymph nodes are larger, we can either bisect it or trisect it, maintaining the thickness of 3 to 4 mm. And if the lymph nodes are more than 2 centimeter, we can do the serial sectioning like a bread loaf. So here in the gross, you can make out the perinodal adipose tissue, hilum region. So it is easy for the orientation also, and the thickness has to be 3 to 4 millimeters. How to write the macroscopic description of lymph nodes? So now we have to mention the type of specimen and the total number of lymph nodes resected from the grossing specimen. Then measurements in all three dimensions. We can measure the largest lymph node in greatest dimension and the smaller lymph node. The external surface can also be mentioned, and the cross section we have to look for any. Here is an example of homogeneous white area. There can be areas, gray areas, hemorrhagic areas, and here are the two lymph nodes which are having central necrosis. So these are from the metastatic lymph nodes. So during grossing, the cross section can give you a hint whether it is reactive or it is neoplastic. So these are some of the photo micrographs to tell you how the necrosis appears in the gross. So in the central area, the solid area represents the lymph node part, and the central area represents the necrosis, and you can see the hue of the adipose. And in such specimens, when you are suspecting there is invasion into the capsule grossly, we can ink the outer surface to check for extranodal extension. And the fresh tissue can be sent for culture sensitivity if you are suspecting infective etiology. And sometimes this tissue can also be retained for flow cytometry, but we need to have a setup for that. It has to be immediately fixed with chilled combination of acetone in 3:1 ratio, and it has to be maintained at minus 20 degree. So, but during grossing, the specimen can be utilized for further molecular analysis if we plan it early. And this is just two examples of level 1A and level 1B group of lymph nodes. Once you remove the lymph nodes from one particular levels, arrange it in ascending or descending order of the size. And this is when the lymph nodes are intact, just write total number of lymph nodes present, and then do the sectioning. So cross section findings you can mention. So this one will go to one particular cassette, and you should not mix up the lymph nodes because you'll never know which lymph node will show neoplastic metastasis, and the smaller lymph nodes can be taken in a single cassette. So this is level 1B group of lymph nodes, and this is after sectioning. Sometimes we come across matted lymph nodes. So it is important to mention in the macroscopy the presence of matted lymph nodes. We have to record the level of the lymph nodes where the matted lymph nodes were seen, and the maximum dimension has to be recorded, and the approximate number of lymph nodes that might be involved in the mass. So that's about grossing of the lymph nodes. Coming to the important segment of the lecture, identification of reactive lymph nodes. So reactive is the term used whenever there is a reaction or a response by a host due to inflammation in absence of neoplasia. So now we know the normal histology of a lymph node and the histological components of a lymph node, and it is easy to evaluate the reactive changes in a lymph node. And there can be changes with respect to the follicle or sinus, paracortex. So, or there can be combination of events. So let us see the morphological patterns. The first one is follicular hyperplasia. This is the schematic diagram of a lymph node, normal lymph node, and this is reactive lymph node. Look at the follicles here. You have primary lymphoid and also secondary lymphoid follicles. And here there is increase in the size and also the number of the follicles. That's why it is called follicular hyperplasia. The follicles are increased in number and also the size. It is mainly the secondary lymphoid follicles. You know what? How does the secondary lymphoid follicle appears? It has pale germinal center in the center, and you have mantle zone at the periphery. So here you can see the variable sized germinal center in a secondary lymphoid follicle with a prominent mantle zone. So mantle zone is crescent shape. It is thicker near the capsule and thinner near the medullary area. So we have already learned a little bit on the germinal center. There is a distinct cellular areas in the germinal center, which is called light zone and the dark zone. Dark zone consists of some larger cells, and light zone has cells with cleaved nucleus. So these larger cells are called centroblast, which are there in the dark zone, and these cells are called centrocytes, which are in the light zone. So what is the difference between a centroblast and a centrocyte? So centroblast are nothing but the B cells, which are medium to large in size. The nucleus is vesiculated, open chromatin, and we can see the rim of basophilic cytoplasm, and it has got prominent nucleoli. If we look at the centrocytes, they are also B cells, but they're little smaller compared to the centroblast. The nucleus is cleaved nucleus, and since the chromatin is dense, the nucleoli is inconspicuous and the cytoplasm is scant. So germinal center is dynamic because it has the concept of polarization. So this is the germinal center. In the center, you can see the dark areas, that is towards the medulla, and you can see the lighter areas, which is towards the capsule. So this is called the polarization of the germinal center. The second pattern is sinus hyperplasia. This is the most common pattern, and sometimes it can be a normal finding in mesenteric lymph nodes. So look at the normal lymph node. You have the medullary sinuses of a particular thickness. You look at the medullary sinuses here, which are expanded, especially in the medullary region. You can see the expansion. Sometimes it can involve the cortical sinuses also. So these areas represents the expanded medullary sinuses, and they're filled with histiocytes. So when it is filled with histiocytes, it is also called sinus histiocytosis. Sometimes it can be filled with lymphocytes also. So this is the hyper of medullary sinus. These are the macrophages, and there are some lymphocytes and eosinophils. So sinus hyperplasia is common in viral lymphadenitis and Rosai-Dorfman disease and histiocytosis X. The third pattern is paracortex hyperplasia. Paracortex expansion lead to the loss of nodal architecture, and it can be seen both in reactive lesions, especially viral lymphadenitis caused by Epstein-Barr virus, cytomegalovirus, and HSV virus. And even in lymphoma, sometimes we can see paracortical hyperplasia. In diffuse hyperplasia, there is diffusely effaced nodal architecture. capsule can be made out, and here is a subcapsular sinus, but the cortex is not showing the follicular arrangement except one for here, and there is diffuse arrangement of the lymphocytes. So this is known as diffuse hyperplasia. You can compare the normal lymph node here, where there is compartmentalization and there is diffuse proliferation of the cells. So this is diffuse hyperplasia. And sometimes you can see the combination of sinus histiocytosis and follicular hyperplasia. You can mention that in the reports. The next segment is on morphological patterns of metastatic lymph node. uh, Evaluation of lymph node metastasis forms an integral component of the cancer staging system. So there is no valid grading system with respect to the lymph node metastasis. The tumoral involvement of the lymph node metastasis almost mimics morphologically to the patterns what we see in the primary tumor. So there can be changes in the capsule, there can be changes, various patterns of squamous cell carcinoma, presence of necrosis, lymphovascular invasion or perineural invasion, presence of mitotic activity, and some additional histological features are seen. So let us look at the changes in the lymph node where there is lymph node metastasis, starting with capsule. So capsule can be thickened, or it can be thin, or it can show invasion. So capsular thickening usually is a sign of inflammation. Uh, uh, so it is seen in inflammatory condition like syphilis, and rarely in Hodgkin's lymphoma. Sometimes in Hodgkin's lymphoma, there is thickening of the capsule, especially in the nodular sclerosis type. This is an inflammatory thickening of the capsule. Thinning of the capsule is seen both in the reactive lesion and in the neoplastic lesion. There is rapid expansion of the tumor, which causes the thinning of the lymph node. So this is the capsule region. You can see the well-differentiated squamous cell carcinoma involving the lymph node and almost reaching the capsule. The reactive lymph nodes can also show thinning because of the expansion or the formation of secondary follicles. But capsular invasion is a characteristic feature of malignancy. The better term used is extranodal extension. It is defined as the extension of metastatic carcinoma within the lymph node through the capsule and into the surrounding connective tissue, regardless of the associated stromal reaction. Stromal reaction can be in the form of fibrosis. So there are three categories. One is absence of extranodal extension, which is denoted as ENEN. The presence of extranodal extension less than 2 millimeters, which is denoted as ENEMI, that is micrometastasis. Presence of ENE more than 2 mm, where it is designated as ENEMA, that is macrometastasis. So these are the two examples of ENE negative and ENE positive. So this is the capsule of a lymph node. You can see some collagen fibers, and they are infiltrated with normal lymphocytes. This is the tumor cells, which are close to the fibrous layer, but it is not involving the capsule. So it is ENE negative. In ENE positive, part of the collagen fibers are infiltrated and it is reaching the adipose tissue component. So this is ENE positive. Sometimes the tumor islands are close to the capsule, and we have to mention that in the report. We can also measure the distance of the tumor islands to the capsule. So here you can see the squamous islands, dysplastic islands reaching the capsule, and here again thin rim of normal capsule and the lot of keratin pearls. So some dysplastic cells are close to the capsule here. Next is about the patterns of lymph nodes. So as we see in the primary tumor, there can be keratinization within the lymph node. So these are the three examples of keratinizing squamous cell carcinoma, which has involved the lymph node. So adipose tissue you can see, but here you can see the tumor islands with a lot of keratin, and these are dysplastic in nature. And there's a huge keratinaceous area here. You can see some lymphoid follicles adjacent to it. And it can be non-keratinizing type. Sometimes it is poorly differentiated type with absolute no keratin. It can be, you can see here, there's no keratin formation, and it has completely involved the lymph nodes. And the tumor dysplastic cells can be in the form of islands. You can see the variable sized islands surrounded by the lymphatics. And you can see the cellular pleomorphism, hyperchromatism, alteration in the nuclear cytoplasmic ratio. And it can also be in the form of cards and strands. You can see the small trabeculae, small cards, extensions here. And sometimes a single file pattern is noted. We usually come across this kind of pattern in the salivary gland malignancies. So this single file pattern is also called India file pattern. There is arrangement of the tumor cells in this way. And we should know about what is micrometastasis and macrometastasis in the lymph node too. So blue color represents the lymph node and red area represents the micrometastasis. So within the lymph node, small islands can go undetected in HND. So this is micrometastatic deposits. Macrometastasis means a larger area of metastasis. You can make out the dysplastic squamous cells here. So this is just to make you understand how the macrometastasis appears. Blue background represents normal lymph node, the lymphoid part of the lymphoid structure, and this is the metastatic focus. Then there is something called ITC, that is individual tumor cells. It is defined as a single tumor cell or small clusters of the cells which are not more than 0.2 millimeters in greatest dimension that are usually detected by IHC but which may be verified with HND. So this is not exactly ITC, but these smaller ones can be called as individual tumor cells, so that according to the definition. So we should be able to identify ITCs. If not able to identify by HND, we can take the help of IHC. Cytokeratin, pan-cytokeratin can be used. Then sometimes there can be cystic change, which is a degenerative change occurring within the lymph node. You can see the macrocyst here, and it is filled with the necrotic debris. And necrosis is also commonly seen in lymph node. So the presence of necrosis not only indicates it is malignancy, it can be seen also in reactive lesions like tuberculosis. But in a squamous cell carcinoma with lymph node metastasis, you can see necrosis, which can be localized or focal, or it can be multifocal or diffuse. You can see here two foci of necrosis. How do you identify the necrotic area? It appears as a pink granular area, and they are usually infiltrated with some inflammatory cells, mainly uh, neutrophils. So there is another terminology called lymphocytic necrosis. Lymphoid necrosis is different from lymphocytic necrosis. Lymphoid necrosis is an area. Many cells are involved. And lymphocytic necrosis means individual cell necrosis, or we can call it as apoptosis. Best example I can give is the mummifying cells, what we see in Hodgkin's lymphoma. It's a form of lymphocytic necrosis. Sometimes the calcified areas can show dystrophic, the necrotic areas can show dystrophic calcifications, which are blue in color. So these are calcifications. And the next important segment is to mention about perivascular or perineural invasion. When do we call it perivascular? When the tumor islands involve one of the layers of the blood vessels. As we know, there are three layers: tunica, intima, media, and adventitia. If it involves one of the layers, then only it is called perivascular invasion. And you should also know the term intravascular invasion, where the tumor cells invade the layers and they are sitting inside the lumen. So that is more significant to mention intravascular invasion. Here it is not perivascular. The islands are no doubt surrounding the blood vessel, but it is not exactly the perivascular invasion. So there is a good rim of normal tissue, and the tumor islands are surrounding the blood vessel. So it is important to distinguish between a blood vessel and a tumor island because both appear little similar in low power. So this is a blood vessel and these are the tumor islands. So these are again blood vessels. So how do you differentiate between a blood vessel and a tumor island? So within the blood vessel, you can see the lumen and the endothelial lining, and you have a coating. You can see the smooth muscle coating, and they are normal appearing cells. So again, you can look for the lumen and endothelial lining, which is like blue dots, the nucleus of the endothelium. Here, here the blood vessel is cut at an angle, so it appears like little elongated. But look for the lumen. Sometimes you can see the presence of RBCs inside the lumen, and this is again a blood vessel. So these are the tumor islands. Again, this is a tumor island. You can see the keratin pearl there. Next is perineural invasion. Again, to call it perineural invasion, invasion should involve one of the three layers, that is either endoneurium, perineurium, or epineurium. So this is a cross section of the nerve. You can see the endoneurium, which is free, and you can see some Schwann cells and the axon cylinder. There is epineurium, and it is not involved. There is a tumor island close to it, but this is not perineural invasion. In this photomicrograph, you can see the tumor islands approaching the epineurium. Here, it appears to be like touching the tissue layer of the uh, nerve bundle. So this is again, this is another picture where in here and here it is trying to touch, and it is like encircling the nerve bundle. So this is the hyper view. So here I can say that it is perineural invasion, but since you're not able to tell which layer is particularly involved, I mean, it is not exactly the involvement of the epineurium. So in such cases, we write it as type B pattern. What is type B pattern? When the tumor cells are in close proximity to the nerve and involve at least 33% of its circumference. So you can see it is more than that, and it is all around the nerve. So then we can call it type B pattern. When do we call it type A pattern? When we can clearly distinguish the invasion in one of the three layers of the nerve. So that is type A pattern. And you can go through an article by Radhika ma'am and the other staff members where they have discussed on the perineural invasion with various patterns. There is a crescent shaped onion skin appearance, partial, all that. And its beautiful schematic representation is also mentioned. You can go through that article. Next is identifying the mitotic activities. You all know about the normal mitotic stages: prophase, metaphase, anaphase, and telophase. So a prophase is the first phase where there is condensation of the nucleus and there is dissolution of the nuclear envelope. So these are the four phases. In the prophase, there is irregularity of the nucleus because of the loss of nuclear envelope. You can look at the adjacent cell where the nuclear envelope is intact. Here it is, a nuclear envelope is dissolved. So to call it a mitotic figure, the nuclear envelope should be lost. So this is prophase. You can see another cell with the prophase. Then metaphase, it is called caterpillar cell. You can see the little elongated structure in again nuclear irregularity because of the loss of nuclear envelope. Third stage is anaphase, where they're retracted to the opposite poles and they're connected through a thread. And again, it is irregular because of the loss of nuclear envelope. The last phase is telophase, where there is a division. Here, the nucleus is trying to gain its shape. There is formation of the nuclear envelope. So it is not that irregular. So this is telophase. You can identify. So you can identify the increased number of normal mitotic figures in a lymph node metastasis, and sometimes you can also see the abnormal mitotic figures in the form of tripolar configuration or star-shaped mitotic figures. Then additionally, sometimes there can be a giant cell response in lymph node. because of the keratin. Uh, so you can see both type of germ cell, foreign bodies type of germ cells and Langerhans type of germ cells. And if they're organized and they're surrounded by the epithelioid-like cells, then you can use the word sarcoid-like reaction, which is little common in both in squamous cell carcinoma, primary tumor, and lymph node metastasis. Again, there is an article on sarcoid-like reactions in the lymph node by Dr. Shivpad Sundaram. You can refer to that article. So there can be giant cell response and the sarcoid-like reaction. So reticulin fibers are the framework. They may not have the significance with respect to the lymph node metastasis, but there are some studies conducted. This particular study was conducted by Dr. Dinsha in our institution. So she checked the staining of the reticular fibers using reticulin stain. The in lymph nodes, the reticulin fibers were long and they were individual in lymph node without metastasis, with metastasis, and they were short and interlacing fibers. So grading system in lymph node is not recommended or it is not validated. So there are grade 4, grade 1 is micrometastasis, grade 2 less than 50% involvement, grade 3 is more of 50% involvement, grade 4 is extracapsular spread. Then TNM staging is the regularly used staging system for oral cancer. TNM staging is upgrading periodically. Uh, Seventh edition was published in 2010, and the newer edition, eighth edition, was given in 2017 Jan. So I'll try to tell you the modifications from 7th to 8th. So in the 7th edition, N category was mentioned as N1 to N3, where N1 was ipsilateral group of lymph nodes involved with less than 3 centimeter. N2A was again ipsilateral, the dimensions were more. N2B was multiple, but again ipsilateral. N2C bilateral, less than 6 centimeter. N3 was more than 6 centimeters. So in 8th edition, the N category was subdivided into P16 positive and P16 negative. So under P16 negative, along with the dimension, the terminologies like ENE negative and ENE positive was added. So now you know what is ENE negative and positive, extranodal extension. And it can be in the form of micrometastasis or macrometastasis, which should be taken as ENE positive. So coming to the last part, how to report lymph node metastasis in oral squamous cell carcinoma. And we have to make sure that to mention the grade of differentiation, the site, and also involvement of the lymph nodes. If there is involvement, mention which group of lymph nodes are involved. If there is no metastasis, lymph node without metastasis, but the grade and the site has to be mentioned. So this is the format or template what we follow in our institution. The type of specimen, what type of specimen is it, tumor site, focality can also be mentioned, and tumor type, tumor grade, growth patterns, depth of invasion, the status of the surgical margin, lymphovascular, perineural invasion, salivary gland involvement, ductal invasion, involvement of the adjacent structures. Then comes the lymph node status. So this is in general for the squamous cell carcinoma. For reporting lymph nodes, we can give the heading lymph node status and mention the levels of lymph nodes, the number of lymph nodes resected from the specimen, number of lymph nodes which become positive, and then mention about extranodal extension. It doesn't matter whether it's micro or major, it has to be taken as positive in when it is there. The number of nodes with ENE should also be mentioned, and a separate mention of matted lymph nodes has to be uh, uh, mentioned, whether it is present or absent with its dimension. Then reactive changes in the lymph node, whether it is follicular hyperplasia or diffuse hyperplasia or sinus histiocytosis, that can be mentioned. So in the macroscopy, type of specimen, now we know what is R&D specimen, MND. So in modified neck dissection, usually one of the things, non-lymphatic structures are spared. So you can have these boxes to write which is spared, whether it's IGV or SCMR, spinal accessory nerve. And we get mostly specimens of SOND, where level 1 to 3 group of lymph nodes are involved that can be mentioned in this uh, template. So just a sample report to tell how to write the macroscopy. Received right partial maxillectomy specimen along with right SOND specimen. Level 1 to 3 group of lymph nodes were received. If it is in separate bottle, mention it. Then other things like maxillary sinus and revised surgical margins received. Total number of lymph nodes obtained. And the largest lymph node measuring the dimension in its greatest diameter, and the smallest lymph node can also be written. Then the gross appearance, that is cut section, can be mentioned, especially when there is necrosis, so that you can correlate that with the histology. This is another example from mandibulectomy specimen, and the lymph node status after histological examination can be written this way. And if it is close to the capsule, even that can be mentioned. So that completes the morphological patterns seen in reactive and neoplastic lymph nodes. Ma'am, can I, do you have
Yes,
little
I'm
more
here.
time?
I'm here. No, I think we will keep those to be covered afterwards or during the discussion
Yeah,
because there are a lot of questions too.
okay, ma'am.
Okay. Yeah.
Yeah.
So that was a wonderful talk. Now I can understand why you were very specific. You wanted to have this presentation and nothing else. So, okay. Now, great. So it is the question and answer time, everyone. All those who are on YouTube, please send your questions in. I would also like if I could find out how many of the people on YouTube are actually our postgraduate students. If you can put a note there saying you're a PG and from where, it will be marvelous. To begin with, I would like to now request Dr. Raghu, who is kindly with us, please take this first set of questions. I think you have the questions with you. I'll hand over to you.
Ma'am, ma'am, can I interrupt?
Yes, you can. Of course.
Ma'am, I want to thank, and I want to give some acknowledgement. Can I finish that, ma'am?
Oh, yes, you
With your
can. You can.
permission. Yes.
Absolutely. You don't need my permission. Please go ahead. Yeah, yeah, go ahead. Where are you? Okay.
Yes, ma'am. Yes.
Yes.
So, to conclude, the lymphatics are considered the sole requisites of the body, and they're so much essential for the immunological modulation. And I can say they play a life saving role. Hope at a lighter note, have I made myself understood? And I fail in my duty if I don't mention about Kumar Swami sir, who is my mentor and who is a wonderful person who has taught me actually to gross. He was more of a pathologist, he used to come to our department and learn about perineural invasions. And he was very encouraging. Thank you so much, sir, for allowing me to understand neck dissection specimens. And two other staff members who have been constantly giving us the specimens, and they're for every case they call us, they discuss with us, and it's really important to have such a good rapport with oral surgeons. Thank you, everyone. And Kavita ma'am, who has graciously allowed me to share all the photomicrographs of the department archives. Thank you so much, ma'am, for all your support. And Dr. Suhas, who was my student, now he is a oncosurgeon. He makes sure to give the specimen and also ask me a lot of questions. And because of his questions, I have evolved as a better oral pathologist. Thank you, Suhas. And I couldn't stop sharing this slide. And this is an RSL which I got it from one of our PG slides. So it was so cute, and I really thought I should share this with everybody. So thank you so much.
Oh, you are welcome. It was wonderful. And yes, that was a lovely slide. I also like your cat in the points to ponder. Of course, I love cats. Sorry. Okay, I'm going to switch off and Dr. Raghu, please take over.
Thank you, Dr. Sanjeev Ayappa, for that excellent presentation. It was personally very informative, and for me, it was truly a masterclass on the lymph node pathology in oral cancer. So, the first set of questions from Dr. Osmani Guerra. I hope I have pronounced it correctly. He's from the middle of the world, Quito, Ecuador. So he wants uh, you to talk to us a bit about sentinel lymph nodes. What are they? The sentinel lymph node, do they have any specific location? How are they located? And how do you identify hidden metastasis in cervical lymph nodes? And of course, these are some of the questions, if you could throw
Yes,
some
sir.
light on.
Yes, sir. Actually, I had a slide for sentinel lymph nodes. So, sentinel lymph node is nothing but the first draining lymph node from a primary tumor. So, this diagram explains the sentinel lymph nodes. So, there is a primary tumor focus. So, the tumor cells can drain into the closest lymph node. The first draining lymph node is called sentinel lymph node. Sentinel refers to the primary echelon. So from here, it can take different lymphoid basins. So this will be considered as the sentinel lymph node for that particular tumor of particular site. So when I was explaining different levels, I told you the squamous cell carcinoma involving the lower lip can first involve the lymph nodes of submental triangle. So for squamous cell carcinoma of the lower lip, level 1A group will be the sentinel lymph node. So it differs for each tumor site. And these are the second tier lymph nodes are also called second echelons. But the second question was about micrometastasis. But sometimes there can be obstruction in the lymph flow between the path from primary focus to the first draining lymph node. So that obstruction can bypass, can make the lymph metastatic cells go into a different basin. So there will be a formation of false sentinel lymph node. So the true sentinel lymph nodes are left out. So this is known as skip metastasis. So there is something called peppering metastasis, that is grossly or on clinical examination, we may not make out there is a lymph node involvement. So that is peppering. So skipping and peppering is usually seen in tongue carcinomas. So for tongue carcinomas, usually the treatment aspect differs because of the issues like skip metastasis and the false sentinel node involvement. So,
Thank you.
and sir, I think they asked about
Yes,
micrometastasis.
how do you identify hidden metastasis in cervical lymph node?
Okay.
And then I think there was also a question on micrometastasis.
So micrometastasis, it is difficult in HND sections, but what at the as a first step, we can do the deeper sections. We can go for serial step sectioning and try to look in HND. And if we are not able to make out in any of those sections, we can go for immunohistochemistry, where a pan-cytokeratin can be used or CK19 can be used, and later molecular techniques can be used, like PCR technique can be used. Isolation of RNA is also tried. So I think we can go further for molecular techniques.
Thank you, Priya. Dr. Mandana, may I ask a question to Dr. Priya?
Yes, sir.
Mandana, I think you are on mute.
I'm sorry. Yes, please go ahead. Please go ahead, Raghu.
Priya, I just was interested in knowing how important it is to grade nodal metastasis.
Yes, sir. So the grading system is given by Lewis et al, sir, but it is not validated. I feel once the lymph nodes are out, the whatever the differential grading is within the lymph node only. Only when there is extra capsular spread, patient should go for further radiotherapy or chemotherapy. And in case of perineural invasion, a surgeon would like to know whether it is extratumoral or intratumoral, what is the caliber of the nerve which is involved. But again, it is radio resistant, so it may not have the prognostic significance in mentioning the grading system within the lymph nodes. But it is not validated. There are some systems, but it will not have the effect on the surgical aspect of the.
Oh, thank you. Thank you, Priya. I have a few other questions. I'll speak to you later.
Yeah. Dr. Raghu, did you finish all the questions?
I had 6 questions.
Okay.
I think I have pretty much. I
Covered
think
them.
Priya has
Cool.
covered almost all of them.
Okay. Sorry. So there is another one which I don't know whether it was covered. Was 1 second from Dr. Kirti. Can you explain the role of ultrasound in differentiative, reactive, and neoplastic cervical lymph nodes?
Uh, like how we look into the size of the lymph node grossly, even in ultrasound, we can measure the size and shape. And reactive lymph nodes are usually less than 1 centimeter, and neoplastic lymph nodes are usually more than 1 centimeter. And the shape in reactive lymph nodes, it is usually ovoid, and in neoplastic, it is round. And then echogenicity can also be checked. And in reactive lymph nodes, it is isoechoic, and in metastatic lymph nodes, it is hypoechoic. And the another one is the diameter of the long axis and the short axis. It is called LS ratio. Usually, a short axis plays a role, and this ratio is high in reactive lymph nodes, and it is low in metastatic lymph nodes. And also the hilum part, there is in reactive lymph nodes, hilum is present, and in metastatic lymph nodes, it is absent. So these are some of the differentiating points between reactive and metastatic lymph nodes with respect to ultrasound.
Okay, there's one more question from Dr. Mondal, who seems to have a problem joining us here. His questions are on YouTube. So, how to diagnose tuberculosis combined with necrotizing metastatic carcinoma if AFP is negative in these cases?
Ma'am, differentiating between tuberculosis and necrotizing carcinoma.
Sorry. What did I say? Tuberculosis combined with necrotizing metastatic carcinoma.
Okay, so we have to look for the primary. If it is metastatic, if it is unknown primary, it becomes a problem. Otherwise, the primary, we should look for the primary tumor, and then in the histology also, it becomes difficult as there is overlapping of the morphology of tuberculosis with. But we have to look. We can look for the metastatic foci. Though major component of the lymph node is necrosed, there can be some component of the metastasis where you can say whether it is squamous cell or it is undifferentiated cell. Then we can go for IHC if you are suspecting metastatic focus.
Right. So also there is another one. First, let me mention, Mondal sir, if you can actually come on Zoom, this will be easier because we'll have a wrap-up discussion. That will be nicer if you are here rather than me reading from there. So please come to the Zoom. I mean, you're logged in. Please come here. Okay, other thing in the meanwhile, I will read from what he has put is role of PET scan in metastatic cervical lymph node.
Yes, ma'am, but it is more reliable, but sometimes the inflammatory focus can also be, it can take up as a hotspot. So, but compared to CT, PET scans are more reliable.
That is true. Very true. I think the main problem with PET scan is that it will show every area of inflammation, basically. That is true. So, before I hope that, I think Barpande sir also is here, but he's not turned on his, okay.
Excuse
So,
me, ma'am.
uh, Priya, yes, you
Excuse
have
me,
any
ma'am.
comments you can add to this? I'm talking about you, Priya NK. Yes. Hi.
I just ask, yes, ma'am, and or highlight on occult metastasis.
Yeah, please.
Priya,
Priya, okay. You're asking Priya
Priya,
for a question. Yes, please ask her again. I think it was not
yes,
clear.
ma'am.
Okay.
Priya, can you for our PGs?
No, Priya, your question is not clear. Maybe you type it into the chat.
Priya, yes, ma'am, sure. Occult
Okay.
metastasis, Priya.
Uh, Priya, she's asking you about occult metastasis.
Which Priya is asking which?
I know the Priya, the NK is asking. Yeah, this
Hello?
was one thing I did
Ma'am,
not foresee when I called two of them together.
Yeah, occult
hello?
metastasis.
Okay.
Can you hear me?
Yeah, I can hear you. Occult metastasis, when metastasis, when clinically we are not able to identify the nodes, which are not palpable, but on resection or in the in the grossing specimen, in the neck dissection specimen, if we try to see the positive nodes, it is occult metastasis. And so that will change the stage migration. So that is the significance of occult metastasis.
Yes. I think Asitha Mondal sir is with us now. Sir, can you turn your
Yes,
camera
ma'am.
on, please? And Barpande sir also is with us. Can you both turn your cameras on, please? In the meanwhile, yes. Hello, sir. Oh, you are not very clear. Okay. And yeah, today we had with us some of our regulars and some others. We have had Dr. Ramakant Nayak sir actually, and Dr. Rastogi, Dr. Kavita, Dr. Uma Devi, Dr. Somia, Dr. Sirisha, Sansri, Dr. Osmani, Dr. Sonali, Dr. Pushpalata, Dr. Nair, Dr. Selvi, Sangeeta Palaskar, Srinivas. Hi, Srinivas. It's all right. You came late. No problem. And actually, many others. And also, I'm happy to say we also got quite a few students with us who joined in and also managed to tell us that they are here. I'm very happy to have seen that, especially since this was definitely for students. We also have Dr. Radhika, and in case I have not mentioned someone, please excuse me. And of course, we have Prakash Patil sir. So I'm very happy there. And yes, now from our panel here, there are no more questions coming there. So any summaries, any statements, Mondal sir, anything you want to say? So if you turn on your camera and turn on your mic, you can speak to us.
Uh, in the meantime, may I ask Priya a question?
Yes, please. Yes.
Yes, sir.
Priya, I think our connection is really good.
Yes, sir.
See, the regional lymph nodes are classified into 6 different levels based on anatomic landmarks. We normally talk about level 1 to level 5. do you want to talk to us a bit about the level 6, which includes the central compartment?
I just know that they are present around the trachea, that is pre and paratracheal, and prelaryngeals. Usually, the involvement is not noted with respect to oral cancer. So, but reporting pattern is same. Like when we write the reporting, it is for left side neck dissection, right side, and for the central compartment, we write it as central compartment. And only in one case of uh, carcinoma X pleomorphic adenoma, we received level 5 group of lymph nodes also. Though it is not the draining site, we received from there, and we lost the patient within a span of a few months. So that the aggressive, it was so aggressive. But I have not come across any oral cancers draining into level 5 group of lymph nodes. It's mainly cancers from the larynx.
So if Dr. Astetwa Mondal is ready with his question. Sir, can you hear us, Dr. Mondal? I think we've lost his connection.
He is mute.
Dr. Mondal?
I'll stop sharing the screen.
Sure. Now, I'm very happy that you brought out the extra nodal extension. What is the normal cutoff that you use in your surgical practice for macroscopic and microscopic E&E, Dr. Priya?
What's up? Normal?
What is the cutoff value that you normally use for the E&E, microscopic and macroscopic?
2 millimeters, sir.
You use
2
millimeters, because in some instances they also say 1.7 millimeters is the usual cutoff.
Okay, so apparently Dr. Mondal sir is unable to actually join us. He wants us to just read his comments, so I shall do that. And these are his comments, so that basically not really questions, they are mainly so that he is giving some information to the PG students. So one of those is single file pattern metastasis is also seen in metastatic lobular carcinoma of breast. That's a very good comment, yes. Then calcification is seen in metastatic papillary carcinoma of thyroid, which is also there. Then, 1 second, yeah. Lymphatic or angio invasion in lymph nodes carry poor prognosis as distant sites may be involved. And we answered that question. Then, what is the importance
of metastasis?
Yes. Yes, Priya. Tell me.
Sir asked the importance of metastasis in left supraclavicular lymph node.
Yeah.
Ma'am, yeah. I have a slide on that, ma'am. I'll try to explain through this.
Yeah, go ahead.
So this is actually when metastatic cancer spread via the thoracic duct, which leads to the enlargement of the left supraclavicular node, and it is characteristically present between the two heads of the sternocleidomastoid. So this particular enlarged node is known as Varsho node, and this can be a first clue in gastrointestinal malignancy. In that situation, it is called Troisius sign. So that is Varsho node, where that is the importance of enlargement of the left supraclavicular node, because there is spread via the thoracic duct on the left side.
Yes. Then,
Priya, one more question is there.
Yeah.
Ma'am, shall I go on?
yes, please.
Is senatal lymph node biopsy useful in oral cancer?
Okay. Sentinel lymph node biopsy is usually used in breast cancers and melanoma, so that they can reduce the excessive or unwanted removal of the lymph nodes. They want to find out which is the sentinel lymph node. But with respect to oral cancers, we can use the technique only when there is N0 neck. And though the practice of sentinel lymph node biopsy started in 1996 for head and neck tumors, it has its own advantage, and it is still in experimental stage, clinical trial stage, and we need to have a setup of nuclear medicine, because that technique involves the injection of the radio nucleotide dye, and we need gamma probe, or even if we use direct technique, it has its own disadvantages because of the skip metastasis. So it is still in experimental stage, and it is not people are trying out only for the trial sake, and it is not started, it is not evolved as such in head and neck cancers.
Right. So I think Dr. Radhika was going to ask something. She was going to comment on metastasis of lymph node. I don't know if that's coming through. So I think we have almost reached. Oh, Pandya, are you there? Would you like to comment on anything? No, I don't seem to think we have. So, anything else, Raghu, you want to wrap up?
No, it was a wonderful presentation,
Are we
Dr.
getting
Priya.
something? Yeah.
I think at some stage it might also be worth looking at the depth of invasion, if it could be a predictor of cervical nodal metastasis, because there are papers where they have stated that if the depth of invasion is more than 10 millimeters, uh, that could perhaps be a novel predictor of the nodal metastasis. And one of the things that we could perhaps do it together as some sort of an ongoing study in the future. That's what I was thinking.
Yes. That sounds very good. There's a lot that can be done here still. And okay, I think we should be wrapping up.
It was very good.
Yes, it was very good. And Priya, there is a lot of very interesting comments. Everyone has enjoyed the talk. And in fact, this time, what I think is, instead of editing and putting back the presentation, which will inevitably make us lose the chat. So instead of doing that, I'll just add the chapters so people can, forward to the next section they want to watch, but I will leave it without editing any sections out so that the chat remains and everyone can see that. So that will be one new thing. Okay, no more questions. Okay, I think it is time for me to share. Um, 1 second. Yes. Are you seeing that?
Yes, ma'am.
Okay. So wonderful. Thanks a lot, Priya. That was a wonderful presentation. Thank you, Raghu. That was very last minute, and thank you for sort of stepping in and helping. Thank you, Priya. And of course, Parpande sir, although we didn't have the benefit of hearing him, I think he was having some technical issues. And Mondal sir, who anyway posted all his questions this side, so we enjoyed his comments and his insights. And well, thank you everybody. I guess we will see you in the new year now. And next week, the episode is going to be on dental practice. It is a dentistry special from Dr. Adil Shroff, who is a oral pathologist in practice, and he's going to tell us how he has COVID proofed his clinic. So that is going to be a practice special for everybody. Thank you so much for being with us. And well, please, while you are here, if you have not subscribed so far, please go and hit that subscribe button so you will be notified every time. Thank you. Have a wonderful weekend. Have a wonderful week actually before you reach the weekend. Yeah, bye.
Thank
Bye.
you, ma'am.
Thank you,
Thank you
ma'am.
so much.
Bye.
Thank you, Priya.
Thank you, sir and Priya.
Well done,
Thank you,
Priya.
sir.
Thank you, sir. Thank you so much.